I'm going to announce first that I am not Marilyn Frazier. Marilyn was in a car accident this morning, and so she asked me to do some aspect of presenting her slide. She is fine. She was not hurt, but her car is towed away, and so she is going to take care of herself. I wanted just to point out that the presentation we just heard is critically important for us as we understand what the complications of trying to develop treatments, real treatments for our population. And this will lead into Marilyn's presentation, but as we know, our populations are not necessarily trusting of the medical community because of the many experiments, the many different types of negative outcomes that have happened to people of color. And so I want to talk a little bit about Arthur Ashe Institute from that perspective. You can start the slides. Years ago, I don't even know. Let's see if I can get this. Years ago, Arthur Ashe came to Downstate, and he determined that, as you know, Arthur Ashe developed AIDS as a result of a transfusion, and he felt that the care he was getting was so superior to that which was being received in communities that he wanted to assure that it would be addressed equally, or that there would be more resources placed in communities to help those people who were suffering with this illness to have better outcomes. So he did come here, and I always start my talk about Arthur Ashe this way and tell you that I'm old enough to have been there when he dedicated Arthur Ashe to this hospital, and the program to this hospital. And essentially, he wanted to make sure that there were researchers here who had an interest in this population and would make sure that the kinds of things that we're talking about today would go into the future. So this first slide talks about the differences between treatment that is equal, treatment that is equitable, okay, and you can see that box in the middle, everybody's kind of getting the same thing, and treatment that is the reality. And as you can see, there's that little guy who's down in the ditch. And so often, our populations wind up being in the ditch when compared to others in terms of resources that are given to the treatments that we all deserve. Arthur Ashe and the Institute have worked to make sure that we begin to do a better job of talking to our communities so that services can be more equal. They can have more equity. And we can approach this from a better perspective. Arthur Ashe really has done treatment in non-traditional settings, and I think it's important for us to know that the work that the Petus have done is rather incredible. The number 3,000 is very high for being able to recruit people in our communities. Generally, we do not like to speak to people about medical issues in a medical setting because there's so little trust. That's getting better. I think that Downstate has gone a long way to improving that, but we still have that issue. And so Arthur Ashe Institute took their initiatives into barbershops and salons, and they actually do programming there where they both ask questions, they do training to really help people within the community get with the program in terms of their health. Okay. As well, Arthur Ashe is also involved in training URM, or underrepresented minority students who are at high school level, and actually they go all the way down to middle school in terms of training students around issues pertaining to our populations. I want to just say that we are very fortunate to have this type of arrangement. There are a lot of places that don't. We're lucky to have run into UAlbany because they also believe in this type of approach. But essentially, this says an agreement to do something together that will benefit all involved is what a community academic partnership is about. Okay, so the strategy for partnerships is bringing people together, building on strengths that exist in the community, and seeing the community as leaders, messengers, and advocates. So Arthur Ashe has developed a community advisory board, and they actually meet with them on a regular basis. That community advisory board has also been of great service to Brooklyn Health Disparities Center. These are people who are in the trenches, seeing what's going on, and really giving feedback about, number one, what types of issues our communities are facing, number two, how we might best address them, because often as professionals, we feel we know better. Not the case. So I won't belabor the point, but it's all about seeing community as a leader, as leaders in developing treatment plans. Okay, so the partnerships center around research, around funding, around resources, commitment to addressing health disparities, credibility. So for many of the places that are seeking to do research in the community, they don't have the credibility to be able to do the types of research that are done here at Downstate. So if a community organization is not affiliated with an academic institution, it is most likely that they will be limited in the types of research they can approach. So we offer them some kind of backup for doing the types of research they'd like to look at, and they help us by providing us with information about the community. The community also offers us dissemination options so that we feed out to the community the findings regarding the research that we've done, the findings regarding what we think should be looked at, and again, we keep getting feedback from the community. As well, the research that community organizations do assists them with building capacity. Right? So I led a mental health agency years ago. And essentially, if you're not one of the big guys, you cannot get resources in the community. And in many cases, these decisions are political. And so you do need to have people you're partnering with to be able to take your treatment further and to make your treatment more pointed and more relevant to the community you're serving. And as well, the partnership offers you the opportunity in both directions to develop expertise in the area you're addressing. Okay, so Marilyn has put this slide here to talk about resources that are on both sides, on community side and on academia side. So CBOs, community-based organizations, have a knowledge of the community. They help with research and health priorities. In some ways, they also understand some of the policy issues. They can help us to develop trust, to develop our credibility, because again, just marching into a neighborhood or into an organization without that trust does not work often. They help with recruitment, and they have that commitment to community and health disparities. On the academic side, we have an expertise in research, and I want to point out that the Patus talked about thousands of people they've seen. And it's not easy to get thousands of people in our community. So many of the academic environments have a hard time because they're not really getting the numbers that would allow them to speak intelligently about what kinds of treatments are relevant for our population. We also have faculty with commitment to the community, and that is part of why we've developed this program, this endowment program, because many times the faculty who are not familiar with the community, who don't study the issues pertaining to the community, don't have the same commitment. And so it is our desire and hope to train underrepresented minority students and faculty who would then turn around and have a commitment to this particular community. Again, on the academic side, we have the tools to help with publication. Publication in the community is not easy. And so for a variety of reasons, there are not the resources to do it without an academic partnership. Funding, of course, which comes through actually doing the larger studies. And I just want to talk about this funding thing a bit. We have some rules as to what types of research we go after. And in general, we have focused, because we're a limited shop, we focused on larger funding or larger grants. Does anybody have an idea of why we've done that? Okay, I'm a different kind of speaker. You gotta talk to me. Why have we focused on larger grants? Wow. Yes. Yes, you. Say that again. Okay. Oh, indirect? Okay, so tell me what that means, Dr. Taylor. Okay, that's certainly an aspect. Would you like to add? I'm going to add a third reason. It sort of doesn't matter what size the grant is, the work on it is the same. So if you're applying for a $50,000 grant or a $250,000 grant, the person who is administering that grant feels that their money is equally important. So if you're going to go for it, as Dr. Salafu has indicated, you've got to submit a lot, and you've got to have some failures, and you've got to be able to withstand that so that you can get to the amount of money that will really help you address the problem. So if you have sort of someone calling you about the grant and making a lot of requirements, and it's $25,000 with which you can do very little, it's better to have a person calling you and kind of helping you to get the larger grant together so that you can really, really do and address what it is that you're addressing. That makes sense? Okay, I've got a couple of head nods. All right. Again, academia always needs to work on credibility, because often people have traditionally gone off on their own, studying what they felt was important without relating to the community. So again, CBOs, community participation, community involvement, very, very important. Okay. Effective partnerships include, first, agreement on a shared goal. Next, decision-making authority, deciding how you're going to include the community in that. And it's not as easy as you might think. Sometimes the grant precludes, sometimes the grant precludes your being able to do things in a particular way, but as much as possible, we want to include community in decision-making. Sharing resources. So here at, I know at Arthur Ashe, there are often times when we do meetings, because Arthur Ashe is a part of Brooklyn Health Disparities Center, and there's every attempt to share resources in that regard. There's training that is offered free of charge. all of that, we try to share as much as possible. And developing the community is a common goal. Okay, so ineffective partnerships, obviously partners who don't share a common vision and values, unequal resources, funds, expertise, etc., unequal decision-making and lack of transparency, hidden agendas do not foster effective partnerships. Cultural and linguistic lapses contribute to poor access to healthcare services. I'm probably not doing this presentation as well as Marilyn would have done it, but I can say to you that the whole issue of how we appreciate culture in all of the things we're studying, very, very important. So I'm on a committee here where we're looking at people's food choices. And of course, we know that food choices have a cultural element to them. But because they have a cultural element, we don't say we can't change this community or we can't help the community to understand what it is that we're trying to say about food choices. Rather, we try to understand what those food choices are about, and we try to give people information so that they can make informed choices about what it is that they're doing in terms of their food. So I'm going to move on. Obviously, if people cannot understand us linguistically, people can't understand us, they really don't know what we're saying. And I've been in situations where patients are sitting before you, doctors or therapists or whatever are just going on and on. The person is doing this, and there is no investigation of whether the person understands what you're saying really. So we have many, many patients who are very compliant. You know, when they go to the doctor, okay, but they don't really understand what the doctor is saying, you know? And that's another cultural issue that we need to know about. For many, many folks in our community, going to a doctor can be this very elevated experience. I have a mother who's had 4 strokes, and so when she's with us, there's a certain level of functioning. When she goes to the doctor, you would think she didn't have any strokes. She pulls it together. Her speech is affected, but it's not as affected when she goes to her doctor. So we just need to know how culture informs how people function. There is, I'm going to skip some of this, but the important aspect here is that information is largely in the domain of health professionals and their institutions. And what that speaks to is how we disseminate. Okay, so if we're disseminating at this very, very high level that no one understands, and it's not English, again, we're going to get this. Yes, we understand. And the person won't do a thing that you've asked, because in essence, you have not made sure that they really understand the information. I'm gonna do understand that I'm seeing these slides for the second time, the first being opening them on my phone when Marilyn called me. So DISRIP is a program that has been started in the city, really trying to address this whole issue of how we include navigation of our health system, how we include health literacy and cultural competency, et cetera, et cetera. There are some people who may be in the room who are involved in it. Certainly, Dr. South, who has been involved with DISRIP, and it's really meaning to address the whole idea of the disparities in treatment, the disparities in how it's delivered, the disparities in resources, et cetera. Arthur Ashe is very involved with DISRIP at this point, and so we just wanted to point that out. This one, I am not sure about. I'm skipping it. Okay. All right, so essentially, This slide implies that the path to achieving health equity involves some of the social factors, including housing, educational opportunities, quality, affordable health care, neighborhood conditions, environmental quality, et cetera, income, et cetera. But, you know, the path to health equity is one that we have to just keep in front of mind, because there are times that we don't recognize what is going on and how people are being affected by what's happening in their community, including the amount of post-traumatic stress disorder our community experiences. I won't go into that. I'm going to, all right, so the role of the community, knowledge of health issues, advocates for change, active partners, which is about the community-based participatory research, and the CAB, which is sharing the research and the policy agenda. The CAB is the Community Advisory Board. And again, as much as possible, Arthur Ashe seeks to engage them in both the research and the potential policy implications. One of the things that we've been struggling with at the Disparities Center is how to turn some of the findings that we have into actual policy. Not as easy as you might think, but we are really at the forefront of trying to address that. And that was really the rationale for having the Borough President's Office involved with the center. Okay, so this is the model for Brooklyn Health Disparities Center. You've heard about this already. And the CBOs are at the center because they actually provide the information that helps us to interpret what we should study and how we should study it. Okay, this is community-based participatory research relationships. I can't even read it from here, but essentially, all of these are factors that go into the way that these relationships go forward positively. All right. This is something that I've had to get used to. Okay. So, community priorities include social determinants. I'm just not able to read it as well as I should, but we've got socioeconomic status, housing, we've got unemployment, we have health concerns, which include, some of the major ones include hypertension, diabetes, and obesity. And these are the research activities on this side and the policy recommendations based upon the healthcare concerns. And this is how Arthur Ashe has really developed their programming. Arthur Ashe, by the way, is a 501c3, so even though they're part of the hospital, they have their own 501c3 status. So they can actually ask for grants and whatnot separate from the hospital. All right. One of the things that Arthur Ashe does with the students is every year they have an actual opportunity for the students to present their research work. And it is so important. You just have no idea how important some of the research is that the young people who go through Arthur Ashe's programming is. They've done things that we've even looked at and said, gee, we didn't think about that. So I'm going to focus on that on this slide. They have a graduation ceremony, but they also have the students actually begin to be able to write. And incredibly, the students are excellent in this domain. The summer internship program began in 2010 for Brooklyn Health Disparities Center. Students were recruited from a program within Arthur Ashe, and they received training. They conducted over 60 research projects, and we've replicated this program in Trinidad and Tobago, which is an incredible occurrence. So Arthur Ashe is international. All right, so these are the lessons learned. Need for innovative intervention programs, culturally tailored interventions are essential to effectively reducing health disparities. Utilizing community resources is important. Bidirectional partnerships are needed, and we should involve the community in all aspects of the program. So for the future, the Arthur Ashe is really interested in getting more participation of the researchers here with the actual CBOs, okay? That's a tough one because often the researchers wish to be somewhat distant from the community and from, the detail of dealing with community partnerships. It's not just smooth and easy all of the time. We should revisit shared research and policy agenda, grant collaboration with CBOs, researchers, and government officials. And in particular, Arthur Ashe does a lot with the Delphi survey, which was mentioned before, but they actually have groups of people meet to discuss various issues pertaining to health, and they give, again, feedback about directions that research should take. Okay, that one is pretty obvious. And thank you.